So I'm Sam Wharton. I'm a tissue viability nurse specialist at Coloplast, and I'm joined by my colleague Charlie, who will be manning the chat. So if you have any questions, please pop them in the chat and Charlie can answer them, or at the end, if we get any time, we can go through any specific questions anyone's got. So today we're looking at making life easier using the three-step approach, specifically looking at leg ulcers. So I think, are we at 7?
Yep. I just want to do a quick shout out if Beverly Hayden is on the call, because it's her birthday today, and she's still joining us. So we just want to say a very happy birthday and thank you for joining us tonight. We hope you enjoy it.
Happy birthday, Beverly. Right, I'm going to just minimize that. And hopefully the screen and everything's working. So like I say, we're going to be looking at leg ulcers today, making life easier using the three-step approach. So our objectives for this session is to effectively assess, prepare and treat our patients with leg ulcers. So we're going to look at a simplified approach to wound healing. We're going to look at some of the impact and the costs of leg ulcers in the UK. Gain an overview of the latest leg ulcer recommendations from the National Wound Care Strategy Programme, and then you're going to leave with the three-step approach, leg ulcer pathway, which will hopefully support you back in practice and be a useful guide when you're looking after your patients with ulcerations on their lower limbs. So, looking at the epidemiology of leg ulcers in the UK, this is some quite shocking statistics, and actually when you look at how old they are now, we know that most probably all these statistics are actually worse now than they were when they were first done. So a study in 2015 found that there were at least 730,000 patients with leg ulcers in the UK, but we know that that's 10 years old now, data-wise. And there's going to be a lot more patients with leg ulcers in the UK. That equates to 1.5% of the adult population having a leg ulcer. Obviously, if you've been around wound care, you'll be familiar with the burden of wound care study by Guest et al. So that was 2 studies. The first one was done in 2012-13 and the second one was in 2017-18, and that showed a 101% increase. So again, that 2017-18 data is now 7 years out of date, and looking at what's happening across the UK, we can anticipate that that's going to be higher again. The number of diagnosed venous leg ulcers indicates that 1 in 170 adults have a venous leg ulcer. So if you're working with patients with wounds, there will be more than likely a higher proportion of the wounds that you see will be patients with lower limb wounds, and most of those will be venous in nature. Now looking at those financial costs of leg ulcers. So leg ulcers cause loss of function. They require long-term care, resulting in a high financial burden to the NHS. So 1.94 billion just in the UK. The average cost of managing a patient with a venous leg ulcer is £7,600 per patient. So if you're seeing a high proportion of patients with venous leg ulcers, you can see that that's going to take a lot of NHS money to manage those patients, and they can even increase to 13,500 for unhealed venous leg ulcers. So if we're not getting those patients in that healing trajectory and we're just managing them, those costs just continue to increase over time. So it's really important that we're getting that accurate diagnosis of the leg ulcer, so we know whether they need to maybe go to vascular to have some intervention, or whether they need that strong compression to ensure they're going to get into that healing trajectory. Otherwise, if we're just managing them, bandaging them up without that strong compression, just wrapping super absorbers around them, those costs are just going to keep on piling up for the NHS. But it's also the cost to the patient. those quality of life factors that we'll go into more details as we go through. So this is the 3-step approach. So this is a simplified wound healing framework that's 3 steps. And the first step is looking at that assessment. So that's completing that really good holistic wound assessment, looking at the psychosocial factors of that patient, the patient factors. So you're looking at their age, their comorbidities, the medication they're on, and then looking at the actual wound. And we separate it into 3. So looking at the wound bed, but also incorporating the wound edge, because it's really important that we manage that to ensure that those edges of the wound can migrate across and close, and then that peri-wound skin, because that wound's not going to heal effectively if the peri-wound skin's excoriated, breaking down. If that exudate's not being managed effectively, that wound's just going to keep getting bigger. So we need to do that really, really good, accurate assessment. Also, when we're thinking about leg ulcers, it's doing that ABPI, doing that lower limb assessment and finding out that etiology of the wound. Really, really key. Then we move on to our step 2. So that's our preparation, preparing our wound, removing those barriers to healing and creating that optimum healing environment. So if we prepare with All Prep Pad, for example, we're just removing that devitalized tissue. We're then able to visualize that wound bed more appropriately and ensure that we're creating that optimum healing environment. And then we move on to that step 3. So that's using whatever products are available on your formulary. Obviously, within Coloplast, we have our 3D FEP technology, which means that our dressings can form down to 2 centimeters, but choosing the most appropriate dressing that's going to manage those management goals you've identified through that really robust assessment. So we're going to go through the assess, prepare and treat, looking specifically at leg ulcers. Sorry. So looking at assess. So what is the aims of our wound assessment? Wound assessment is fundamentally the key to ensuring that our patients' wounds heal. It's about identifying that cause of skin breakdown. So when we're thinking about our leg ulcers, it's determining whether they're venous in etiology or are they arterial. They might be a mix, but until we've identified that, we can't give the most appropriate treatment. It's identifying any associated risk factors for that patient. So it may be that some of their medications might need to be reviewed. It might be that they're diabetic and we need to be looking at their blood sugars to ensure that we're making sure that the patient's optimized to create, again, that optimal wound healing environment in the actual patient themselves. It's to ensure that we correct or treat that underlying cause. So again, it's that compression. If it's venous in nature, until we get that strong compression in the treatment phase, we're never going to truly heal that wound because it's just going to continue to break down. It means that we're identifying appropriate management options. So again, incorporating that communication with our patients, not letting them sort of just hand their leg over to us, actually having those discussions and giving them their options in their care. Control those wound related symptoms. Pain's often not looked at enough for our patients, and pain is a real contributing factor as to whether or not they're going to agree to certain treatments. If they're in lots and lots of pain and then you're suggesting putting on compression, they'll often say, no, it's too painful. We need to address their analgesia, their pain, to ensure that they will then be able to tolerate the most optimum treatment. It will prevent further skin and wound deterioration. By doing that full assessment, we'll be looking at how much exudate's present, whether that exudate's being managed or actually is the peri-wound skin breaking down because the exudate's sitting on that peri-wound skin. Is there wound deterioration because there's a bacterial burden within that wound bed? Do we need to manage that and get rid of that bacterial burden to ensure that wound's going to heal? It also helps us identify the patient's expectations, and we can have those in-depth conversations with our patients. And it also helps provide that psychosocial support and promote patient independence. So we know that the NHS isn't going to be getting any more money. We know that we need to transform and think differently. And one of the big sort of national wound care strategy that was discussed is looking at that supported self-management. So by having these really good assessments, identifying and talking to our patients, you may find that patients can actually take on some elements of supported self-management. So we need to be thinking and making sure that we're working in partnership with our patients. So it says here, wound assessment can be complex, with reasons for this being multifactorial. Using a simplified wound assessment framework, such as the triangle of wound assessment, can help simplify the process. So the triangle of wound assessment was created with tissue viability specialists, and it's a simplified framework that makes sure that you identify all areas when you're looking at your assessment. And this is what we'll go through when we look at our assessment. How often should wound assessments be carried out? A holistic wound assessment, so that's that full wound assessment, so that's really doing a really robust full assessment, should be done every 2 weeks in an acute setting and every 4 weeks within a primary care and community setting. But obviously every time you're removing a dressing, you're doing a wound assessment. You should be recording the size of the wound, taking photography if you've got the ability within your setting to do that. But those really, if that wound's not progressing, you should be identifying that really, really quickly to ensure that you go back to that real full assessment and see if something's been missed, or do you need to get other specialties involved to support you? Because often what I've seen over time as a tissue viability nurse is that we just sort of end up being quite task orientated. So we go in, we'll take a dressing off, we'll put a dressing on, but we don't ever actually look and say, well, has this wound progressed at all in the last month? If it hasn't, we need to go right back to that assessment again. If it is progressing, that's great. Is it progressing as you would expect? If not, again, has something been missed? What do we need to do differently? We need to get out of that mindset of just managing wounds. We want to be healing wounds. And if they're not healing, we might need to call on other professionals, or we might have to do something different, because patients' wounds should heal. Not absolutely every wound will heal, but most wounds will heal. And if they're not, their primary function isn't to heal, we should have that documented somewhere. So if it is a case of we're just managing the symptoms, then we need to have that documented, and again, still have a treatment and a strategy for that patient. So this is the triangle of wound assessment. So it's a holistic wound assessment framework to assess all areas of the wound. Like I said, it's looking at those socioeconomic factors, those patient factors. And then when you're looking at the wound, it's looking at the 3 areas. So that wound bed, wound edge, and peri-wound skin. And to ensure that we're making that optimal clinical decision, all 3 areas of the wound should be considered. So when we're looking at leg ulcers, I'm sure anyone that's been looking after leg ulcers in their clinical practice will be very much aware of all these underlying indicators of venous disease. So you've got that significant past medical history, you know, if they've got DVT, a PE, lower limb fracture, these are all potential indicators of venous disease, varicose veins, family history of venous disease. We've also got those indicators of venous disease. So that ankle flare, varicose veins, that pigment and staining. So obviously in that image you can see there, you can quite clearly see that venous staining on the lower limb. Edema, eczema, dry skin, all of these are indicators of venous disease, atrophy branch, and pain and heavy feelings in the legs. So I'm assuming most of us have been in healthcare or working in healthcare. And, you know, when you finish your shift, sometimes your legs feel quite heavy and achy. And I think sometimes whenever I do sort of teaching and I say, who here wears compression? I'm lucky if 1 or 2 people say that they wear compression, but you know, we are high risk of developing venous disease just by the nature that we're standing for long periods of time. And then you've got other risk factors, so medical conditions, hypertension, chronic edema, hormonal. Then you've got your lifestyle, so obesity, physical inactivity, stress, history of IV use, occupation. So like I say, being nurses, on our feet all day, chefs, policemen, those sort of occupations are going to be at higher risk of having venous disease. And then again, with us ladies, the multiple pregnancy, because you're putting that pressure on that feet, on your circulatory system with the pregnancy. And again, it's another contributing factor. So it's really important that when you're looking at your lower limb assessment, you're identifying these risk factors within that assessment, and then it will give you a guide as to where that ulcer is in nature, that etiology of the wound, whether it's going to sit more in that venous disease or arterial. Looking at arterial now, so you can see on these 2 images, very punched out, lower down on the leg, and some of the significant medical history, so cardiovascular problems, stroke, MI, angina. So these are all sort of indicators, or you'd be thinking that might be more arterial in nature. Indications of arterial disease, so intermittent claudication. If you're not sure what that is, it's where people are walking and they'll get cramp, and that's where they're struggling for that blood to get around the foot, and they'll get this cramping. So sometimes people can only walk sort of 100 yards and they're getting this cramping, and that's that intermediate claudication. Pain on leg elevation. So if patients say they go to bed and after an hour or 2 in bed, they wake up with pain in their lower legs, and then that's relieved when they put their legs out of the side of the bed. That's often an indication of underlying arterial disease, because what's happening is while they're laying flat in the bed, the blood can't get down because it hasn't got gravity helping it. When they put their legs over the side of the bed, gravity's helping them, and that pain in the lower leg goes. Extremities of cold, so their feet will often be very cold, again, because that blood's not getting down there. They'll have discoloured toes, thick and slow growing toenails, dependent rhubarb, so the leg will stay very, very red when the gravity's helping the blood get down. So that's another indication. Absent foot pulses. So I don't know in your clinical practice if you listen to foot pulses and find foot pulses, but that's another real key part of doing your lower limb assessment. Pale, shiny, hairless skin. So again, because that blood's reduced in the lower leg, the hair follicles, they don't have that nutrient, so they fall out. So the legs often look quite shiny and they are absent of the hair. And the ulcers present quite deep and punched out. And the ulcers are more common on the lateral malleolus and dorsum of the foot. So some of those risk factors, again, hypertension, diabetes, rheumatoid arthritis, and then the lifestyle. So smoking, obviously, you're going to be more at risk because you're going to be clogging up those vessels, high cholesterol, obesity, physical inactivity, and stress. So again, through doing that, having that conversation, that assessment with your patient, looking at these 2 indicators, through that assessment, you'll find that patients will sit usually more under venous or more under arterial. And if they're mixed in nature, you might have a bit of both of these risk factors within. But again, really important to record and make that part of your lower limb assessment. So now we look at that wound bed assessment. So we need to look at the tissue types and the exudate and any signs of infection, whether that's local or spreading or systemic infection. So when we're looking at the tissue type, we've obviously got necrotic. So if that black, hard necrotic tissue is there, and sometimes it can be quite soft necrotic tissue, sloughy, that yellowy, devitalized, can appear quite stringy. And then you've got your granulating, so those nice pink granular cells, and then your epithelialization. When we're looking at the exudate, we need to record the volume of it. Is it dry? Is it low, medium, high? We need to make sure that we're recording how much exudate's present. The consistency, is it thin? Is it watery or thick? And also the colour, is it clear, cloudy, purulent, pink, red? We all know those signs of infection. So those local signs of infection, the increased pain, erythema, edema, local warmth, increased exudate, delayed healing, that friable granulation tissue where you literally start cleaning the area and the granulation just bleeds really, really easily. Healthy new granulation tissue shouldn't bleed easily when you're just cleaning an area. Malodor and pocketing. And then those signs of spreading in systemic infection, that increased erythema, pyrexia. Often the patient will say, I just don't feel well, the wound's breaking down, general malaise, and then you would start doing your further investigations, and you would escalate that patient because they need more urgent support. Sorry, I'm really struggling with my nose. Sorry. And then you look at your wound edge assessment. So that maceration, you can see really clearly in that picture, that white ring around that wound. So those cells are swelling up with the exudate that's sitting on there, and it just breaks down. And if it's not managed effectively, that wound will just get bigger and bigger. Then you've got that dehydration. So that wound needs moisture. When you've got a dry area of eschar like that, it's not going to heal nicely. You're going to end up with scar tissue. We know about moist wound healing, and we need to create that moist wound healing environment for these wounds. Otherwise, the epithelial cells just dig down and you end up with quite nasty scarring. And then you've got undermining. We need to make sure we record that effectively. So we make sure we measure it, whether that's with a probe, or a finger sometimes can help you just to make sure that you're measuring, and then put it against the ruler. But we need to make sure that we're recording that really, really accurately, so that our next people going into review can make sure that's wounds improving. And then rolled edges, really hard to manage. Sometimes need surgical intervention to actually be able to encourage those epithelial cells to close. Can also be sometimes a sign of carcinoma. So if those rolled edges aren't being helped with sort of a normal cleansing and management of that wound edge, it might be worth having a biopsy if they've been there for a long period of time. Then we're looking at our peri-wound skin. So again, we've got that maceration, but if you look on this photo, you can see that's going right down to the heel. So that peri-wound skin as well. So that exudate's really not being managed at all. And that wound's just going to continue to break down. Excoriation. So on that photo, that looks like that's been caused by a dressing being taken on and off, or and you can see it looks red, it's inflamed. Then we've got dry skin. I don't know if anyone's taken off TED stockings or hosiery where the patients had dry skin, and you get like a snow globe effect with all the dry skin coming out. It's really itchy for patients, and it needs to be managed to make sure that you get that good skincare regime in place. Then you've got that hyperkeratosis. Again, it needs to be removed. It needs good skincare and management to ensure that you don't get those ulcers breaking down underneath where the moisture can build up, and then you end up getting ulcerations. Then you've got callus. So clearly on that foot, that looks like a Charcot foot. That would be managed by podiatry. You might have shared care with that patient, but that callus needs to be removed and debrided away. And then you've got eczema. Sometimes needs some steroid just to calm down that inflammation with the eczema. Again, needs to be managed, otherwise you're just going to end up with more complications and further wounding of that lower limb. You might need to do further investigations to aid diagnosis. So following your own work policies and procedures, you might need to do a full blood screen. You might need to do a wound swab, again, follow your own localized procedures and policies around this. Really, really important that if it's an ulcer on the lower leg, that you do that ankle brachial pressure index to make sure that you can either compress if it's venous in nature, or if it's arterial in nature, if they need further referral to another specialist. So it may be that they need to go to vascular to have some further intervention. And then also doing that pressure perception to see whether there's any neuropathy in our diabetic patients. So the National Wound Care Strategy came up with their recommendations, and this was really a game changer, because I've been in tissue viability for 15 years and we were always told not to put compression on until you've done your full lower limb assessment, including an ABPI. But with these new leg ulcer recommendations, we're now able to apply that reduced compression of 20 millimeters of mercury as long as none of those red flags are present. So it's a real game changer, because you're getting patients into some reduced compression on that first presentation. So you're not having to wait to get them in to have that full lower limb assessment and ABPI before you can get them into some sort of compression. So I don't know if or where you're working, but hopefully you're aware about these leg ulcer recommendations. If you're not, please look them up. The National Wound Care Strategy Programme is actually coming to an end. So they've got some really good resources on their webpage, but you do need to go on there sooner rather than later and download them, because like I say, the actual programmes come to an end and those resources aren't going to be available for much longer. But you really need to go on there and make sure you've saved them somewhere, because it just gives you those resources that can support you in your clinical practice. So those red flags are acute infection. So if your patient presents with acute infection, symptoms of sepsis, acute or suspected chronic limb-threatening ischemia, suspected DVT, suspected skin cancer or bleeding varicose veins, then you would not put any compression, reduced, just no compression, and you would immediately escalate to those relevant clinical specialists. But if they present to you with a wound on their lower limb, they've got no red flags, then absolutely get them into 20 millimeters of mercury on that first visit. You still need to then book them in within 2 weeks to have that full lower limb assessment, get their ABPI, and then go into that strong compression if that following that assessment that's indicated, because that's obviously the gold standard. That's where we want our patients to be if that's the most appropriate treatment. But this just gives you that in-between time to be able to get the patient into some sort of compression. And actually, by getting them started on that treatment, explaining to them how it's going to support them, you'll then find that compliance will be better moving forward when you then have to go up to that stronger compression. Like I said, it's still really important that you arrange for that comprehensive full lower limb assessment within 14 days. Really important that you treat any wound infection, clean the wound and surrounding area and apply an emollient. Do your normal digital imaging if you've got the facility where you work. Apply a simple low adherent dressing with sufficient absorbency. Again, like we've said before, if that exudate's not managed and it sits on that peri-wound skin or wound edge, that wound will break down further. So it is really important that the dressing that you choose is adequate for the amount of exudate that's present. For those without red flags, offer that mild graduated compression and then signpost to relevant high quality information. If there's suspected venous disease with an adequate arterial supply, refer to vascular services. So hopefully everyone has a good referral system into vascular services, and then apply that strong compression therapy. Suspected venous disease and peripheral artery disease. So if the ABPI is less than 0.5, urgent referral to vascular. If the ABPI is more than 0.5, refer to vascular services. Other uncertain etiologies, refer to those appropriate services. ABPI more than 0.8, consider the use of strong compression. So that is where you would start putting your patient into that strong compression. And then hopefully you'll have lymphedema services, again, where you can refer in. So again, looking at the ABPI, so it provides an index of vessel competency by measuring the ratio of systolic blood pressure on the ankle and arm. So less than 0.5 suggests severe arterial disease. So I always think of it as 1 being all the blood going down to the leg, 0.5 is half the blood going down to the leg, 0.8 is 80% of the blood going down to the leg. So that just helps me when I visualize it. So if it's less than, so half the blood is getting down to the leg, that's severe arterial disease. Compression treatment is contraindicated because what you can do is then reduce that blood even more, and you need to revert to an urgent vascular assessment. 0.8 to 1.3, that's where you can apply that compression, and that's that strong compression, so 40 millimeters of mercury. If it's greater than 1.3, that suggests arterial claudication, so the vessel's not actually being able to be compressed, and again needs to be referred to vascular for assessment. Greater than 0.5 to less than 0.8 suggests the presence of arterial disease or that mix, so it could be a mixed arterial venous disease. Compression should be avoided, but reduced compression could be used under specialist advice, and again refer for a vascular assessment. Really important that once that assessment's been carried out, you confirm the action plan with our patients. We need to work together in partnership with our patients. We need to make sure we've discussed what we're going to do, what, if any, special investigations need to happen. Will there be team involvement or referral to other team members? Details of that specific treatment. Like I said earlier, plans for that supported shared care if it's appropriate, and having those conversations right from the beginning, and giving some ownership and empowering the patient to have some element of care of their ulcers is really important. Then also discussing our plans for discharge. So we know that 70% of leg ulcers reoccur. So we need to make sure that the patient's aware of, you know, if they've got venous disease, they've in that compression, it's not a case of once that leg ulcer's healed, you don't need the compression. It's obviously that's a life now of needing that compression to stop that reoccurrence. So we've gone through step 1, which is our assessment, and now we're going to move on to our step 2, which is prepare. So when we're working, we may face lots of challenges, and these are just some of the examples. These wounds are quite challenging in their presentation. So that first photo, you can see you've got that excess fibrin and slough. It's also undermining. On that middle picture, you've got that necrotic tissue, but you can also see there's a bacterial burden there, and that needs to be managed. Not only that, but once that necrotic tissue has been lifted, you might have underlying structures exposed. Also, that heel on that middle picture looks quite red, and you know you might lift up that foot and actually have necrotic heel as well. So it's really important that you assess every aspect of the lower limb when you're reviewing them. And then you've got that hyperkeratosis. Well, that you know that's going to feel really, really uncomfortable to that patient. Most probably have a bit of an odour there, and it needs to be removed because, like I said earlier, ulcers can form underneath that hyperkeratosis if it's not removed, and we need good skin care to ensure that we're doing that. But how do we manage that? When you're suddenly presented with that, how do you get that wound, that area into a healing trajectory? And it's really important that we prepare our wounds to ensure that we're getting them in that best optimum healing environment. We know that 80% of non-healing wounds contain biofilms. Hopefully you've all heard of biofilms and aware of them within your clinical practice. So biofilm is a structured community of microorganisms with genetic diversity that create that chronic infection. They're characterised by a significant tolerance to antibiotics and antimicrobials while remaining protected from their host defense. So basically the bacteria, the microbes, they produce this polysaccharide coating around themselves that protects them, so that any antimicrobial that you're putting on top of them, they've basically got this lovely protection. You often talk about, when we talk about biofilms, like an umbrella, and they're sat under that umbrella, and anything that you're putting on top, it's not being able to penetrate and kill that bacteria, because they've surrounded themselves with this polysaccharide coating. Not only that, but they talk to each other and they live in these communities. Biofilms are in the environment. They've been in the environment since day dot. When we look at ponds, you know, sometimes you've got that sort of that slimy substance around the edge of a pond. That's biofilm. Around your taps, sometimes you'll get that sort of black slimy thing. That's a biofilm. So they are everywhere in the environment, but they cause a real problem in a wound bed because they reform. So even if you are able to remove some of them with your mechanical debridement, they reform. So we need to make sure it's a frequent part of your treatment plan. It's not a one-off and you get rid of them and that's it. Because they do reform, it's a constant. You need to make sure that you're putting in a good biofilm management strategy for those patients with chronic wounds. And like I say, 80% of non-healing wounds will contain a biofilm. They're not visible to the eye, but their presence would be seen as those sort of classic signs of infection. So that delayed wound healing, that increase in exudate and slough, that's because they keep it in that increased inflammatory response, erythema, malodor, and that high bacterial load. So when you've got a wound and it's just static, it's not progressing, that will be the biofilm sitting within that wound bed, causing that wound not to progress. So it's really important that we manage those biofilms effectively. So the international best practice for management of biofilms and infection. So they again, it's a 3-step. So it's doing that wound preparation. So it's cleansing and debriding to reduce the number of microorganisms by disturbing and removing some of the biofilms. Applying a barrier dressing that's going to prevent that maceration. It's going to manage the exudate, and it's also going to prevent that recontamination. So you want a dressing that's going to lock that bacteria away. It's really important. Otherwise, that bacteria can go back into that wound bed. And also that infection management. So you want that dressing with the active agent that's actually going to be able to suppress that biofilm formation and reduce the existing biofilms and microorganisms. So we need to remove those barriers to healing. By cleansing and wound debridement, we can remove barriers to healing, such as slough and non-viable tissue. So you can see in that image, you can see where you've got that non-viable tissue and biofilms, and then by removing it, we make sure that we progress those wounds to healing. This is a retrospective study. So it was a retrospective study of 312,000 wounds, and it showed that when they looked specifically at the diabetic foot ulcers, that if a wound was debrided once a week, the mean time for that wound to heal was 21 days. But if the diabetic foot ulcer was debrided once every 2 weeks, it took a further 76 days to heal. So the mean time to healing was 76 days. So this just illustrates the more frequent you're able to do that debridement, the quicker the wound's going to heal. And because this is a very large study, although it was done retrospectively looking at patient records, again, it just illustrates that we need to be doing this biofilm treatment, this debridement, regular, necessary to ensure that wounds heal in a shorter period of time. So there's different types of debridement and cleaning that we can do. So we've obviously got washing and cleansing. That doesn't require any extended competency and training. Then we've got other types of debridement. So autolytic debridement, That's the body's attempts to shed the devitalized tissue with the use of moisture. So it's the dressing that you choose to create that moist wound healing. Then the body's the own body breaks down the dead tissue, and it clears away that devitalized tissue. Then we've got mechanical debridement, so physically removing that devitalized tissue. So obviously within Coloplast, we've got our all prep pads. So that's a form of mechanical debridement. Biological debridement, so that's larvae, maggots. And again, they do a really good job at removing that tissue, but they need to have the right environment. Too wet, they drown. Too not enough dead tissue, they eat each other. And just being also conscious of where it is on the body and pressure, because you can end up squishing them. Enzymatic debridements, that's ointment gel that contain enzymes that again will soften and lift that necrotic tissue. So those types of preparation in the lighter blue, they don't require extended competency or training, but they do require to have some knowledge and skills. And then you've got your sharp and surgical debridement, so that's the use of scalpels, forceps, and they do require extended skills competency. It's usually a module, and then you get signed off by a surgeon or podiatrist to ensure that you've got the competencies to be able to do that sharp debridement. So the National Wound Care Strategy Programme recommends the wound and surrounding skin are cleansed and debrided. And this is an image of the all prep pad. So hopefully you've seen that or aware of it. If not, at the end of this session, you can request a contact from one of our team, and they can go through the aspects of the all prep pad. How often will wound preparation be required? So it's down to your clinical judgment, and that's really important. But like I've said previously, we know that the more regular you're able to do that wound preparation to disrupt that biofilm, to get rid of any devitalized tissue, the shorter the healing time. And I know for me, if I had a wound, I'd want it to heal in a shorter time as possible. But you do need to also look at your assessment. So that, again, it's really important you're doing that really robust assessment at the beginning. Use your clinical judgment, look at what your treatment goals are, and also addressing the patient's pain levels, because it may be that you need to get the analgesia sorted first before you start doing any type of debridement. Because I know that if I went to a patient who, you know, the type of patient where you go to take their dressing off and they're already on the ceiling, and then you try to do some form of debridement, they're not going to let you near their wound ever again, because we need to manage that pain first of all. There are times when we need to be cautious with our wound preparation. So here's a few examples. So if a patient has a wound on a lower limb and is known to be diabetic, if the patient has any known arterial flow concerns or poor localized tissue perfusion, and if the patient's immunosuppressed because of medications or underlying medical conditions, then we need to just be cautious. So you may need to refer to specialists within your area just to get that confirmation and discuss that patient. So we've gone through our assessment, and we've now gone through our prepare, and now we're going to move on to our treat. So when we're looking at our treatment objectives, so wound assessment and preparation leads to identification of our objectives. But the most important thing is identifying and treating the underlying cause. Because if we haven't identified what the cause of that wound is and treated that element of it, that wound's going to break down or it's not going to heal in the first place. So that assessment is so key in identifying. So when we're thinking about our leg ulcers, the key to a wound on the lower limb is doing that lower limb assessment and identifying if they're venous in nature, arterial in nature, mixed in nature, because then you can ensure you're getting the right treatment for the patient in terms of that compression. So once you've identified and treated that underlying cause, you then need to make sure that you're looking at your management and prevention of what you're trying to achieve as part of those management goals. So if there are exudates present, is there exudate or exudate pooling? How are we going to manage that? What dressing do we need to ensure that that exudate pooling is not going to happen, and that the exudates managed and not breaking down the peri-wound skin? Do we need to add any protection of the peri-wound skin to ensure that that skin's not going to break down, and again the wound's going to increase in size? We don't want maceration or excoriation. What do we need to do? How do we need to manage that? If that wound's got any depth or cavity, how are we going to manage that? If there's undermining, and we need to use a filler, making sure that we've identified that within our treatment plan. And then also looking for those signs of infection, whether they're subtle signs or those more classic signs of infection, and how are we going to manage that with our dressing selection, our antimicrobial effect, what antimicrobial we're going to use, and how are we going to ensure that we're getting the outcome that's best for the patient. There are various different types of dressings. You need to know what's available on your formulary, but these are just some of the commonly used dressings. So you've got foams, you've got antimicrobials, hydrocolloids, contact layers, gelling fibres, alginates, odour absorbing, hydrogels. So you'll have lots of different dressings available to you, and it's looking at your assessment and what your management goals are and choosing the most appropriate for that patient. What we don't want to do is start layering dressing upon dressing, because that's often where we've not chosen the right dressing, and actually we're having to counteract the dressing by adding another dressing in. For example, if you're using a super absorber but you're having to put a contact layer in because the super absorber is sticking into the wound bed, then that's not the most appropriate dressing for that wound at that point. Being a tissue viability nurse, I've seen many layering of dressings, and it's really counterproductive in what's trying to be achieved. So, you know, wound care doesn't have to always be complicated, and I think sometimes we make it a lot more complex, and actually just simplifying it and choosing the most appropriate dressing can actually have a much better outcome. So the National Wound Care Strategy Programme recommends the application of a simple, low adherent dressing with sufficient absorbency. On this photo, we've obviously got our foam, which is the biotane silicone, which does actually conform to the wound bed. So again, you're not needing to add in a filler, because that dressing will manage wounds up to 2 centimetres in depth without having to add in those extra layers. It's really important that that strong compression therapy is started with venous disease. And the National Wound Care Strategy also indicate the use of the hosiery kits. So it's a type of medical compression therapy most commonly used for the management and healing of venous leg ulcerations. And the hosiery kits are really good because for patients that are able to support themselves with that supported self-management, it's a way that they can ensure that they're getting that compression. And you can be more confident that you're getting the right compression at the right areas within the lower limb. With bandaging, it's down to the clinician that's applying it. The kit consists of 2 medical compression garments, and they're designed to be worn one on top of the other. So they usually contain 2 liners and 1 stocking, although I think there's a lot more out on the market that's actually just 2 stockings. So 1 stocking that's the reduced 20 millimeters of mercury, and then the second stocking that takes it up to that strong compression. So it's designed to deliver that 40 millimeters of mercury of pressure at the ankle, reducing to 20 millimeters of mercury at the calf. Recommendation is, while there's an active ulcer, to be worn for 24 hours. The outer layer can be removed at night, but often you're better off just keeping it on for the full 24 hours. And they're available in off-the-shelf forms or made to measure. Obviously, if your patient has lots of edema and they haven't got that good leg shape, then you'll need to go into bandages first to get that good leg shape for them to then be able to use the hosiery kits. So this is just in a case study. So this is a 90-year-old male with no comorbidities. He had a mixed etiology leg ulcer that was present for more than 10 years. His ABPI was outside normal parameters, so he wasn't suitable for full compression. And he wasn't he didn't have the confidence to travel since he'd had the wound. Like we say, he'd had it for more than 10 years. He was 90 years of age. So, you know, he missed out on 10 years of potentially going and traveling due to this wound. So following the 3 simple steps of assess, so a really thorough assessment was carried out and the management goals identified. So to create that optimal healing environment by preparing the wound bed, edge and peri-wound skin, it was to remove that non-viable tissue, manage the exudate, manage that bacterial burden, protect the granulation, epithelial tissue and protect the skin. So on day 1, you can see it's quite dark in presentation. And even by day 3, you can see that that wound bed looks much healthier and the peri-wound skin looks much healthier. So for the prepare element, the wound was prepared with all prep pad. And then for the treatment, it was treated with biotin AG non-adhesive. And as you can see, by day 54, the wound was progressing really, really well and on to healing. So after more than 10 years, he was actually healed just following that really simplified 3-step approach of assess, prepare with all prep pad and treat. Mr. H had found the wound preparation too painful to tolerate, but since introducing all prep pad, it could be tolerated, and his wound made visible and significant progression. He was then able to tolerate 10 millimeters of compression, which was a liner after day 3, but previous to that, he wasn't able to due to the pain and the exudate. After managing the infection and exudate levels with biotin AG non-adhesive, he was then able to help share his care by using biotin silicone and hosiery. And by day 54, the wound had healed. So what a great outcome for Mr. H, having the wound for over 10 years. And then by using that assess, prepare and treat, he was healed in 54 days. So this is a 60-patient evaluation that's been carried out using the assess, prepare and treat. So from this 60-patient evaluation, 4 patients were identified to have a simple leg ulcer and 32 patients were identified to having a complex leg ulcer. And this is just the indications of when the ulcer was defined as a complex leg ulcer. I'm not going to go through all of those, but for most of you working with anyone with leg ulcers, most of your leg ulcers will sit within that complex leg ulcer. And the overall leg ulcer results were the average time that those wounds had been present was 73.2 weeks. And by following assess, prepare with all prep pad, and then treat with dressing with 3D fit technology, the average healing time was 6.5 weeks. And out of those patients, 79% of the patients healed. So that was 34 out of the 43 patients. And even the patients that hadn't healed were on a healing trajectory. So their wound was on a pathway to healing. It's just it didn't happen within the time of the evaluation. Another really positive element that came out of these evaluations was that no patients received any antibiotics during the evaluation period. So prior to coming on to the evaluation, over half of the patients had had a course of antibiotics, and it worked out at 1.5 courses per patient. But as soon as they started on this assess, prepare, treat, no patients received antibiotics. So again, thinking about our antimicrobial stewardship, doing that wound preparation, removing that bacterial burden, disrupting that biofilm, and then using a simplified dressing that managed the exudate and locked away that bacteria, no patients needed antibiotics. Looking into the simple leg ulcers, the average wound duration was 8.75 weeks, and they were healing on average in 3 weeks, and 100% of those patients healed. The complex leg ulcers were present on average 39.23 weeks, and average healing time was 6.3 weeks, and 91% of those patients healed. Again, the ones that hadn't healed were on a healing trajectory. Nobody received any antibiotics. So we've gone through the 3-step approach of assess, prepare, and treat, and hopefully you've got some have some thoughts and be able to take back to your clinical practice when you go back. This is a really simple pathway that you'll get after today's session, that you can use and refer to. So if the patient has any signs of, does the patient have any signs of arterial insufficiency? If they do, then dress as per your local guidelines and refer to your specialist. If they don't, then you can do your ABPI, prepare the wound for healing, and like we say, you can do that reduced compression. And then it's all about doing that wound preparation, reviewing the wound. Is it improving? Yes, continue with your current management. If it's not, review that holistic assessment, go right back to the beginning. Have you missed something? Is something happening? Do you need other specialist input? And then we've also got a product selection guide at the back, just again to help you identify that simplified approach, that simplified framework. So doing that assessment, preparing the wound using all prep pad, and then treating it. So if the patient's got compression hosiery or in leg wraps, there's no signs of infection, you can use Biotane Silicon or Biotane Silicon Light. If infection's present, Biotane Silicon AG. If the patient's experiencing pain, you've got Biotane IBU. If they're in compression bandaging, then you can use the Biotane Silicon non-border or Biotane non-adhesive. If the infection's present, Biotane AG non-adhesive. And again, if they're experiencing pain, Biotane IBU. Like I say, you'll get given sent this after today's presentation. So please use it and refer to it as you need. We've also got additional support for our products and services. So we're excited to announce that we're now able to offer you a follow-up telephone call. And like I say, people can go through either face-to-face or virtual education on our products and services. So you can either scan that code that's currently on the screen. And we've also got our podcast called Wound Care Conversations. So if you like listening to podcasts, they're available through your normal platforms. We've actually got a few more than 5 now. I think there's quite a few more out there. So if you're driving around, I don't know if you're in community or you like listening to a podcast, then please do download it, and you can listen to Charlie and myself. And we've got guest speakers as well. So I think that's it for tonight. Hopefully I haven't taken up too much. Oh, got 2 minutes. So I'm just going to unshare. Hopefully. Have I unshared? I think I've unshared. Yes. IT is not my thing.
That was really brilliant. Thank you, Sam.
Sorry, I have to apologise. I've been snotting and yeah, sorry, and coughing. But hopefully that's all made sense to everybody. Is there any questions or anything that's come through, Charlie?
No, they've been very quiet. So they've obviously been listening to you throughout. Just to reiterate that you will get sent a copy of the recording of tonight's webinar. You will also receive the pathway and a certificate. It might not be sent to you immediately after this finishes, but we will get them sent to you in the next few days or so. So I have put in the chat the link to Coloplast Professional, where you can have a look to see what other events we've got coming up. We have got some product-based webinars coming up in March. that goes through All Prep Pad in a bit more depth if anyone wants to join that. But the if you have a look at the events page, then all of the webinars are listed on there that we do. There's lots of thank yous coming through, Sam, for a very informative session. It was brilliant.
Oh, and if Bev, you're still here, happy birthday.
Fab. So that's it from us, everyone. Thank you all for joining, and especially taking time out of your evening, and Beverly, out of your birthday, for joining us. And we hope to see you again soon. Thank you.
Bye.